So the reason we study critique in this particular semester is because you've had positioning in the first and second semester, and you've had 4 full semesters of clinicals, so that you should have a pretty good understanding of what the projections look like. You've seen enough images that you can determine, or should be able to determine, when an image is good and when it's bad. What you may not have been able to develop are understandings of what makes it bad and how to correct it. So that's what we're going to study in this semester. So the purposes for studying critique would be to limit repeat exposures, not just in a single exposure, but we're going to go back through positioning as well, so that it's a refresher and a reminder of exactly where we position for particular images. But if you perform an exam that needs to be repeated, you should be able to analyze your image and determine exactly what you need to do in order to correct for the mispositioning or the wrongful exposure, so that you can limit your exposure to a single repeat. So you're going to learn to develop your critical thinking and to limit your number of exams that you have to repeat, but certainly limit the number of repeats on a particular exam to 1. And so that reduces radiation protection, it improves radiation protection for the patient, lowers radiation exposure to the patient, and it is to maintain standards for the hospital, and it is your professional obligation to the patient. So that is your way of demonstrating your professionalism as professional growth. So you need to be able to visualize and understand when an image needs to be repeated, when it needs to be submitted, when there truly is a likelihood that the image can't be improved, and what an optimal image looks like. It also improves efficiency. If you limit your repeats to a single repeat as opposed to 2 or 3 repeats on a particular patient, then certainly it improves your efficiency. So we're going to evaluate for marker placement, we're going to evaluate for radiation protection, we're going to evaluate for positioning and rotation, angulation, whether or not our angulation is accurate. We're going to evaluate for pathology. We're going to evaluate our patient pre-exposure for pathology as well. We're going to make sure that we include the correct anatomy. We're going to make sure that we set the correct technique, and then we're going to study correction as well. So terms, we're not going to spend a whole lot of time on terms just because you know what these terms mean. It should be a review for you now. But anterior is front of the body, distal is away from the head, which is very similar to inferior. Inferior being below, you can have something that's distal and then have something inferior from that as well. Lateral versus medial. Keep in mind that lateral is a position, is a projection, it's a body surface. Lateral side is your outer portion. Lateral position would be where you have the patient in a position with one side closer to the image receptor, and then lateral projection, remembering that the position, body position, projection in a lot of cases are opposite from each other. You have a lateral medial projection, medial lateral projection, things like that. So medial's on the inside, oblique is somewhere in between a frontal and a lateral projection. Posterior is the back, proximal is towards the insertion, superior is above, as opposed to it's opposite from distal, or inferior rather. So you got planes. Keep in mind that whenever you're reading a test question, if you're looking at a question that asks for left and right portions, that would be a sagittal plane. If you're looking at, if a test question is asking you about a plane that divides you into equal left and half right portions, that would be a mid-sagittal plane. Same thing with coronal. If it divides your front and back sections, that would be a coronal plane, as opposed to a mid-coronal would divide you into even front and back portions. So abduct and adduct are the only body movement references where doctors will routinely spell out a portion of the word just because they sound so familiar or so similar. You know what alignment is, you know what an artifact is, artifact being just anything on the image that should not be there. They can be indwelling artifacts, they could be external artifacts, they could be imaging artifacts, equipment artifacts. There's a lot of different types of artifacts. But if it's on the image and it shouldn't be there, then that's an artifact. Caudal, cephalad, convex, concave, we should talk about in class. Condyle, as opposed to epicondyle. Remember, the condyles are your articular surfaces, as opposed to your epicondyles are above the condyle. And usually the condyle being the articular surface is not what we palpate. The epicondyle is usually what we palpate. So a depression is a portion of usually a bone. We're talking about a depression, but it goes into the bone, usually in a linear fashion. You know what detail is, you know what deviation is movement away from or towards a anatomy, a specific anatomy, and it's deviation away from normal. So if you're standing in anatomical position, it's somewhat relaxed, but if you flex your wrist towards your ulnar side, that would be ulnar deviation or ulnar flexion. Dorsiflex is specific to the foot, as opposed to plantar flex would be the opposite of dorsiflex, where dorsiflexion is pulling the toes back towards the shin. Plantar flexion would be pointing the toes. Elongation and foreshortening are opposites. Elongation means that the anatomy or the structure looks longer than what it should, as opposed to foreshortening, it looks shorter. Flexion is a bending of a joint, whereas extension is just that. It's a straightening of a joint. It's the extension of a joint. Lateral rotation, external rotation is the same thing. Magnification, you know what magnification is. Keep in mind that we've got a couple of different types of magnification. Size distortion is your magnification, but unequal magnification is your elongation or foreshortening. Medial rotation is the opposite of lateral rotation, so it would be internal rotation. Medial rotation would be OID, you know what that is. Palpate, you know what that is. Plantar flexion, we talked about that. Profile would be the outline of an image, like whenever we shoot a AP of the shoulder with the arm in external rotation, what we see is the greater tubercle and profile. So projection, we've got a couple of different things for projection. That's image appearance due to body position. We also have projection of the central ray. So we project the central ray, cephalic, caudad, lateral, medial. But what we use oblique positions, as well as cephalic and caudad angulation on our central ray, is to project anatomy off of other anatomy. So we got pronation is to turn the anterior surface down. If a patient's laying on their stomach, they're pronated. If they're laying on their back, they're supinated. Protraction and retraction are specific to the mandible. Protraction would be where you jute the mandible out, so you got an underbite, as opposed to retraction would be to draw the mandible back in so that you have an exaggerated overbite. So you know what radiolucent and radiopaque is. Remember that radiolucent is something that easily passes x-rays through it. That doesn't mean it doesn't absorb anything. It just means that most x-rays are going to go through it. As opposed to radiopaque, it's going to absorb most of your x-rays. In recorded detail, remember we got sharpness, we got visibility. Remember everything that we talked about last semester that affects both of those. The sharpness, we're looking at OID, SID, motion or lack of motion. We're looking at focal spot size, geometric factors, as opposed to visibility or recorded detail is primarily about what causes or what cleans up scatter radiation. Retraction, we just talked about. SID, you know what that is. Superimposition, you know what that is. Supination, we talked about that. Symmetry means even on both sides. Trabecula are just those little spiderweb looking bony markings in extremity work. So what we're going to be looking for an optimum image is to make sure that the image is identified properly, that is properly marked, that the anatomy that we want to see is present and optimized, really, that our contrast is good, that our contrast resolution, our density is good, our image resolution, that is your sharpness or recorded detail is good, size and shape are accurately reflected, the anatomy is accurately reflected in size and shape on the image. Did you demonstrate radiation protection? Can we point to the image and say, okay, well, we've got collimation there, we've got use of shielding, and absence of artifacts where possible. So our display or radiographs, some of your departments are very specific on your marker placement and orientation. Make sure you follow those protocols. The way we view images are going to be specific to the individual images. So on chest x-ray, we're going to look at the image as if the patient was upright, unless we're looking at a decubitus. Decubitus is generally viewed in the orientation the patient was presenting. So left lateral decubitus, the x-ray would look like the patient's laying on the left-hand side, as opposed to a PA chest, upright chest is going to look like it's upright. Same thing with the abdomen. With an upright abdomen, we're going to look at it as if it's upright. A KUB, we're going to look at it as if it's upright. But also, if the patient is, we're doing a decubitus abdomen, we're always going to do a decubitus abdomen with the patient on the left-hand side, unless there's a specific reason we need to put the patient on the right-hand side. But we're always going to look at a decubitus abdomen without contrast, as if the patient's laying on the left-hand side. So anatomical position with the patient lateral. I've worked in hospitals where the patient looked like they were, we hung the images as if the patient was looking to the right. And I've worked in hospitals where lateral chest x-ray looked like the patient was looking to the left. So again, hospital protocol you've got to follow there. So you'll view or demonstrate, display the image as the patient was positioned for your decubitus, your axiolateral hips, your shoulders, things like that. For a lot of your extremity work, we're going to look at the big bone on top. So from the elbow through the shoulder, we're going to look at the big bone on top, the ankle through the hip, big bone on top, then a little bone on top for fingers, hand, forearm, toes, feet, ankles. Ankles not. That's back up to big bone on top. But regardless of what we cover here, your go-to is to make sure that you follow the physician's preference, hospital protocols. So what do we have to have on the image? We have to have the minimum to make it a legal document is the patient's name and age, the facility name, the examination time and date, and the marker. And a lot of your hospitals, instead of using the age or in addition to the age, sometimes they'll use the date of birth. The reason that they want to use the date of birth instead of the age or in addition to the age is because it makes it a little bit more specific. Conceivably, you can have two patients in the hospital with the same name. Actually, it happens all the time. The likelihood that you're going to have two patients in the same hospital facility name on the same time and date where you have the same exam is still possible. Happens not quite all the time, but it happens. I've gone to a floor with a portable machine and taken an x-ray on two different patients with exactly the same name. The likelihood of having a patient with the same name and same age in the same facility with the same examination time and date and having the exam taken by the same person is pretty rare. But if you throw in date of birth, that's 365 more possible differences in the identification of the patient. In other words, you can have two John Smiths that are 35 years old, but two John Smiths that are 35 years old, both born on, let's say, December 3rd of whatever year 35 would make that would be pretty rare to have all that similarity in one hospital at one time. Kind of trip through that, but you kind of get the idea, I hope. So marker placement, my personal opinion on marker placement is make sure it's on the image, out of the anatomy, and the image is properly marked. Left side represents left side, left anatomy is represented by the left marker, and so forth. Some of your hospitals are very particular, and you just got to follow the departmental protocol. The Buc-ee's have gotten so thin now that they will eat your marker at the drop of a hat, so I understand people putting the marker on the tabletop. I've seen some images where the marker looks like it's about 3 times the size it should be. And that's because some people will put the marker on the patient themselves. I really don't recommend you do that. The marker really needs to be as close to the image receptor as possible. Some of your hospitals will have you flip the marker around for anterior AP projections versus post PA projections to identify what position the patient was in, if they were in an anterior or posterior presentation. Again, I don't think I've ever worked in a hospital that was that specific and particular on the marker placement, but there are some who are. Some hospitals have a collection of markers, accessory markers that you would put on the image that might identify specific positioning. If we took a shoulder series and internal versus external rotation, they may require those markers as well. Your Merrills mention that your marker should always be on the lateral side for extremity work, and again, some of your hospitals are pretty particular on that. My personal opinion and my personal use and experience is that most of your radiologists don't care where it is, as long as it makes sense. It marks the accurate anatomy or side of the anatomy, and if it's not in the required anatomy. The appendicular skeleton, that would be on the lateral side. Just make sure it's out of the anatomy. Axial skeleton, again, follow your hospital protocol. Generally, if I'm going to put a marker on the image receptor inside of the Buc-ee, I'm going to put it on the side of the image receptor that is going to travel the least inside of the Buc-ee. In other words, if the Buc-ee slides, if you're shooting PHS X-ray and the image receptor slides in from the side of the patient who where it would be on the patient's left-hand side on a PA chest X-ray, I'm going to mark that image left because the distance that it's going to have to travel inside of the bucky is only going to be a couple of inches, and therefore the bucky's less likely to eat it. If you put it on the bucky itself, the tabletop, that's okay. It doesn't really matter if it's left or right that way. Decubitus, really depending on the patient's body habitus and whether or not I can see the image receptor without anatomy on it. In other words, if I can see the light field on the image receptor, I'll probably put it on the upside. But if I'm shooting let's say a decubitus chest X-ray for a pneumothorax, and there's any chance at all that I could get the marker inside of the lung field, I'll go ahead and mark the downside. The lateral side needs to be marked on the side closest to the image receptor, and you may have some differences whether you're going to put that on the anterior side of the patient or the posterior side of the patient. For C-spines, I tend to put them on the anterior side. I know a lot of people put them on the posterior side. As long as it's marked on one side or the other, or if you're following departmental protocol, physician's preference, then you're going to have to mark something specific. Keep in mind that your collimators can be off and still be within regulations, so you never collimate down to the skin line. Your collimators can be about 1/2 of an inch off, so you need to open your collimators up not just to the skin line itself, but past the skin line 1/2 to 1 inch, just to make sure that if your collimators are inaccurate by the amount that they are legally okay to be inaccurate, that you don't, by collimating down to the skin line, that you don't clip anatomy. So over collimation always, if you over collimate and you delete anatomy or you clip anatomy that should be on the image, then it's counterproductive. It defeats the purpose of collimation. So over collimation always defeats the purpose of collimation itself. Collimation is really a radiation safety issue. It does help with the image quality as well, but the primary reason for collimation is to improve radiation, improve the radiation dose for the patient. So it does help in a digital world. It helps the computer to identify the proper volume of interest. It can help with visibility or recorded detail by reducing scatter radiation. And since it helps the computer to identify the volume of interest, it reduces histogram analysis failure, especially in CR systems where your collimated borders can mean the difference between an image that the collimated field that the computer can make sense out of and give you a good image, or a collimated field that the computer can't make any sense out of, and you get a horrible image. So it's your obligation to know what your hospital routines are, what the preferred positions are, and why. You may have to ask some questions if you have like some sort of perceived ethical bias against particular exams. You may have to ask somebody, why do we do this? But the routines are your preferred positions, and it's okay to ask, for guidance or understanding why you do things in a particular way. AP versus PA. Why do you do AP versus PA chest X-rays? Is there a time that it's appropriate to do AP chest X-rays? And understanding the anatomy and how it's affected by both projections, development, and also pathology helps you to understand when it is appropriate to shoot alternate views. What I mean by that is that kids have anatomy that's a little bit different than adults. So the most obvious is the skull. You take a 2-year-old and tell them to touch the top of their head, and they have to extend their arms all the way up in order to touch the top of their head. So they got this normally abnormal, huge head, but they also have a great big heart. So I've worked with radiologists who came to us from pediatric hospitals who told us that fundamentally there's no real difference in perceived heart size in children below age 7 shooting AP versus PA. The radiologist should know that the heart is going to be big on kids from 7 years old or under. So the question then becomes, if you're taking a x-ray on a pediatric patient, what would be the easier way to get cooperation from that patient to shoot the image, AP or PA? Well, probably AP, instead of cramming the image receptor directly into the patient's face and scaring them half to death. If they're, say, a 2-year-old child, just turn them around on the table and shoot them AP as opposed to shooting PA. So things like that. Upright versus recumbent. We've been through why we shoot chest x-rays upright versus having the patient laying down, and that would be better inspiration. The engorgement of the great vessels in the thoracic cavity gives you an appearance of a widened mediastinum with the patient laying down. So a lot of different reasons to shoot them upright. Air fluid levels. What do we do to two views 90 degrees from each other? That would be so that we have depth perception. With x-rays, all we get is a single, well, 2 dimensions. We get length and width, but we don't get any kind of depth. So 2 views 90 degrees from each other gives us some degree of depth perception. So what does off-centering cause? And that would be what we call a parallax effect. It's seeing anatomy where it is not. And the reason for that is because of the angulation that would be on a x-ray tube whenever it's not aligned to the center of the anatomy. What I mean by that is the beam diverges. So if you're not centered to the center of the anatomy and you're centered too low, then what you're seeing in the center of the anatomy is an angled central ray. So SID and OID issues are going to give you things like magnification and loss of sharpness of recorded detail. Angulation, again, is going to give us unnecessary angulation. Is going to give us foreshortening, or I'm sorry, elongation most of the time. That's angulation of central ray. Angulation of anatomy is going to give us foreshortening. So we're going to look for telltale indicators that we have accurate positioning. We're going to look at where the bony projections should appear as opposed to where they do appear on your image. We're going to look at what anatomy is anterior versus what anatomy is posterior, so that we can identify where the anterior anatomy should be in relationship to the posterior anatomy. We need to be able to identify what should be superior versus what should be inferior, and therefore if they're superimposed, what kind of problems we had going on there. We're going to look at similar anatomy. We'll look at magnification, be able to identify rotation, angulation of either the anatomy or the central ray or both. And we'll look at issues like magnification, foreshortening, and elongation. Most of our obliques are 45 degrees or somewhere close to that. But whenever we get to things like the T-spine for oblique of the T-spine, which we rarely shoot, but we do, the positioning is about 70 degrees, so it's close to a lateral. Lateral being 90 degrees, 70 degrees would be closer to a lateral than what it would be to an AP. So in order to adequately positioned for oblique of the T-spine, just imagine 45 degrees and 90 degrees and going halfway in between that. That would put you at 68 degrees, because half of 45 would be 22 and a half. We'll round that to 23, so 23 plus 45 puts us at 68 degrees. That's close enough to 70 degrees that you're not going to see any mispositioning between 68 and 70 degrees. So correction for rotation, we're going to take a look at what anatomy should be anterior, what anatomy should be posterior, what anatomy should be superimposed, and then we're going to, with those three things in mind, determine which way the rotation needed to go versus which way it did go, or how much rotation we should have versus how much rotation we do have. Same thing with central triangulation. If we're over-angled, where is the anatomy? Where should the anatomy be? If it's over-angled, where is it? If it's under-angled, where is it then? Also, though, we need to take into consideration that thicker anatomy separates the structures quicker than thinner anatomy. So, pre-exposure, we need to evaluate our patient and determine how much rotation or how much of an angulation we'll need. If you'll think all the way back to the first semester, whenever we were doing clavicles, the purpose for the apiaxial clavicle was to project the clavicle above the apex of the lungs. That didn't take a whole lot of angulation with a hypersthenic patient or a patient with a big, thick barrel chest, but whenever we had an asthenic patient, it took more angulation. So that's kind of what we're looking at there. So for the required anatomy without obstruction, what we want to see and evaluate is whether or not there's superimposition, whether the superimposition is supposed to be there. If it's not, then what went wrong? We want to take a look at collimation, make sure that we've got some radiation protection going on. We want to look at the rotation. Is it present? Is it supposed to be present? And how to fix it. We want to look at malpositioning of the patient, radiation field, and the image receptor. So we're going to look at bony detail, everything that involves bony detail, sharpness of recorded detail, visibility of recorded detail. Are the trabecular patterns accurate? Did we use the right focal spot size? Did we use the proper OID and SID? Is motion present? Are there any kind of digital artifacts like a double exposure or ghost image? Is magnification present? Is elongation or foreshortening present? Was our technique right? If we used AECs, did we use the right AECs? Did we get a good exposure to the AECs? Did we position the anatomy over the AECs? Should we have used a grid? If we did, is there was the grid adequate in its cleanup of scatter, or do we need to go back to our technique again and adjust that? So evidence of radiation safety, was the communication between the floor nurse and ward clerk adequate? Was the communication between those people and the doctor adequate? Did you get a good order for the patient? Does the order make sense? Is it the proper exam? Is it the proper patient? Take your history. Find out whether or not the patient was pregnant where appropriate. Select your proper SID. Make sure collimation is used. Shielding is used. Make sure you use the right image receptor size where appropriate. Make sure your image receptor orientation or your collimated field is appropriate. Look for all different types of artifacts. Does the exam match the order? And sometimes it will, sometimes it won't. Sometimes it will match, it won't match the order, but it accurately reflects what the doctor wants to see. In other words, I've had cases where I got an order on somebody, let's say for a wrist. I go to the ER room to pick the patient up, and they're in a wheelchair with their foot elevated and bandaged up, but the wrist is okay. The wrist appears to be okay. So I asked the patient what happened. Well, I sprained my ankle. Okay, well that doesn't jive with my order. So I go to the unit clerk or the doctor and I ask, is this accurate? And what I would learn is that the patient already came back for one X-ray of the ankle. The ankle was okay, and then before they left, the doctor might have asked the patient if they had any other concerns. The patient complained of pain in the wrist. So before they released the patient, they took a look at the wrist. So sometimes it doesn't match, but there's a legitimate reason why it doesn't match. So it doesn't hurt to ask. Sometimes it matches, sometimes it doesn't.